Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare and life sciences. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the lawyers at Epstein Becker Green, a leading law firm that has decades of experience serving clients in the healthcare and life sciences industries nationwide.
Today on Diagnosing Healthcare, we will discuss the recent national focus on health equity, the actionable interventions behind the concept, and the responsibility for stakeholders in making care delivery more equitable. Hello and welcome. I'm your host, Marjorie Scher. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice based out of our New York office. Under the Biden administration, the Centers for Medicare and Medicaid Services published a health equity framework which aims to advance health equity, expand coverage, and improve health outcomes for government payer enrollees over the next 10 years. EBG views the health equity framework as the latest attempt to transition care delivery from a sick system, which reacts to individuals once they've fallen ill, to a whole person well system, which invests in preventative care and non-medical factors, which impact an individual's overall health. We understand that this represents a seismic shift for health plans and other risk-bearing entities and poses several questions around benefit design and reimbursement for both medical and non-medical health-related services. So on today's show, we're going to talk about how health plans, accountable care organizations, and other similar stakeholders now bear significant responsibility of successfully creating and administering social determinants of health interventions as a means to forward health equity. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. Joining our discussion today are two individuals that I have the great pleasure of working with regularly. First, Kevin Malone, a member of the firm based out of EBG's Washington, D.C. office. Kevin draws on more than a decade of experience working on healthcare financing policy and law to help managed care organizations navigate the web of federal and state regulations and program policies governing healthcare financing systems. Kevin, thank you so much for joining.
Thanks so much, Marjorie. It's great to be here.
Also joining us today is Jackie Selby, a member of the firm in our New York office. Healthcare providers, as well as insurers, employers, and technology vendors, look to Jackie to address their unique managed care issues, reimbursement, network participation, and regulatory compliance challenges. Jackie, welcome to the podcast. Thanks for joining.
Thank you, Marjorie. Pleasure to be here.
I think where we want to start today is making sure that we're all on the same page as to the vocabulary. I personally hear health equity and social determinants of health going hand in hand, but really we could devote an entire Diagnosing Healthcare episode to each of them on their own, let alone how they might be the same or how they might differ. Kevin, in a nutshell, how do you think about health equity, social determinants of health, and the interplay between the two?
Thanks, Marjorie. The way that I think about these concepts is that I see health equity as a reframing of what in earlier administrations, particularly the Obama administration, was focused around the concept of disparities, which is really a concept of how health outcomes are determined by many things, such as your zip code, in many ways that have more determinative prediction of your healthcare outcomes than your genetics or other sort of social determinants of your health, which we'll talk about next. There are many different populations, people with disabilities, race, socioeconomic status, gender, where people in a certain category have been shown through public health and epidemiological data to have worse outcomes, higher mortality rates, higher morbidity rates, and in many cases, just lower and worse access to what we consider to be modern and effective healthcare services. Thinking about health equity as something that should be addressed as an independent policy objective and trying to address that history of disparities, that's really how I think about health equity as a concept. It's really a concept of fairness, a concept of justice, and trying to understand how the healthcare system and the legacy of racism, the legacy of discrimination, and persistent current discrimination on many different domains of identity and representation lead to really unacceptable outcomes in people's lives. Social determinants of health, on the other hand, is really a specific public health measure of identifying in individuals' healthcare outcomes that there are aspects of their social existence, like housing, their community, the level of services in their community, their experience with stress, their experience with trauma, that end up being really significant predictors of their actual somatic health outcomes, and trying to have our healthcare financing and delivery system look at people as whole individuals, not just blood tests, blood pressure, as people that are shaped by their lived experiences and their social and material environment, and trying to incorporate services and activities like care management, like housing support, like supportive employment that are targeting those sort of social experiences that drive people's healthcare. But they are really different from each other in the underlying assumptions and the framing of social determinants and health equity. Although, as you framed in the introduction, services related to addressing social determinants of health can be a really primary vehicle for trying to address health equity goals as well.
Interesting. And Kevin, I heard you brought up a lot of things that I think we, as those interested in health policy and fairness, think a lot about: food, housing, transportation, and some newer things like supportive employment. So, Jackie, is health equity, as Kevin just described, a total novel concept to you? Or do you think that this is really an existing rose that we're just calling by another name under this current administration?
I think it's a little bit of both. I mean, to some extent, concepts of health equity have been around a long time. Kevin mentioned that. Non discrimination obligations in healthcare delivery, they've been part of the structure for decades. And the principle of caring for those who get healthcare and social services in our safety net is not new. With the creation of Medicare, Medicaid, and other social services, our government has signaled that they feel a moral obligation to make care accessible. Of course, we don't have a single payer system, and there will continue to be holes in our safety net. But another novel concept is the reimbursement for services being tied to those health equity goals, putting our money where our mouth is, so to speak. And the movement towards value-based payment. Medicare payments to providers, for example. CMS recently added street or outreach sites as a reimbursable site of service for physicians providing care to unsheltered homeless people. Bonus plans to hospitals and Medicare Advantage plans have their star ratings impacted based on their health equity index. And Medicaid has reimbursement policies that differ by state. It can vary for performance of reporting and training and eligibility and reimbursement. So all of those are novel, some are old, and some are new.
Interesting. I see that you took a little bit of a health plan perspective here, which makes sense to me. I know that you're a former in-house counsel to a large health plan. And so, Jackie, what do you see as the payer's role, their specific role in fostering equitable healthcare delivery?
Plans today do have some very specific goal requirements put on them, especially government plans like Medicare Advantage and Medicaid. And commercial plans typically follow what's been rolled out in Medicare. And at some point, I think plans, regardless of the legal obligations, will have a hard time maybe going back and changing what's been out there, putting the genie back in the bottle if it becomes part of the delivery system and patients and employers value those changes and there have been improvements. Plans are following the lead of the government, but at some point, I think their customers will like to see these changes continue.
And so, do you see this as being something that's specific to government payers, or health plan consumers in general may advocate more strongly for health equity intervention, sort of regardless of who the payer is?
Yes, I think once patients are familiar with them and have access to things that they think are helpful, then I think they will expect or they'll go to their employers or they'll ask for them. So I don't think it's just government. Medicare has been rolling it out in the context of ACOs under traditional original Medicare. So ACO Reach is the perfect example. And I think that patients are becoming used to that in the context of traditional Medicare, and government plans are rolling it out, and the commercial plans, I think, will follow.
Great, thanks. And Kevin, do you mind expanding on that a little bit? How are you seeing CMS foster health equity more in the traditional Medicare setting or in the fee-for-service Medicaid setting?
Yeah, I think Mina Sishwani, the sort of current deputy administrator for Medicare, has made health equity a real strategic priority for her time in that role, and has aligned with her sort of colleagues who run federal Medicaid and the Centers for Medicare Medicaid Innovation. They've written a number of interesting things in health affairs, laying out their vision for how federal health insurance programs have not just an opportunity, but an obligation to approach their work in covering and reimbursing for healthcare services with a health equity lens. And they've deployed that in a lot of different ways. Jackie mentioned in ACO REACH, a CMMI demonstration model. They have adjustments in the benchmark used for calculating shared savings on the basis of sort of area deprivation as a metric of assessing relative disparities in access to healthcare. They're making tweaks in it for 2024 and are really working hard to find ways of creating incentives really for ACO entities and other demo participants to invest additional and more resources in targeting traditionally underserved communities and communities that have demonstrated health disparities from an equity perspective. That's sort of one of the ways they're thinking about doing that. But they also have more qualitative approaches, such as making ACOs develop health equity plans. And I can say from my experience working with clients, they're quite serious in their review of the adequacy and substance of those health equity plans that they make ACOs submit as a programmatic compliance obligation. And they've taken similar efforts like that within their insurance administration role across original Medicare. They've done that in some of the physician reimbursement metrics, some of the inpatient outpatient hospital programs. They're trying to incorporate health equity adjustments and health equity incentives and obligations across every opportunity that they can find. So it's definitely not something that they're doing just as a health plan obligation. They're trying to use every fee-for-service tool that they have to push in the same direction.
Interesting. I think a lot about the health equity plans. As you say, they're a requirement by CMS for these ACO programs and CMMI demonstrations. But we also hear that word being tossed around in the private sector as well through the Joint Commission and URAC and other sort of accreditation bodies. How, in your mind, do you compare and contrast the health equity plan that's required by CMS to some of the health equity plans that are required or encouraged in the private sector?
It's a great question. And I think the biggest difference is that, at least for the demonstration models that have been required to develop and implement health equity plans, the CMMI is dedicating specific resources around technical assistance to the ACOs around what should be included in an effective health equity plan. And they're really putting the screws through rejections and potential compliance actions of plans that don't seem like they meet the expectations of CMMI with regards to like specific actionable strategies and really demonstrating that the ACO is doing something, not just putting it on paper. And I don't think that sort of across ACO consistency that you have from like a single regulator trying to push the same strategy and same set of expectations across all of the participants exists in any of the commercial manifestations of health equity plans, which are really self-developed, really are developed voluntarily, and are part of potentially a broader care management strategy or even public relations strategy. And so the interplan variability in what those health equity strategies constitute is much greater than what you're going to see in a program where it's actually mandated and is a subject to programmatic oversight.
Thanks for that perspective. The way that I think about it is to differing extents, everybody is interested in dipping their toe in the health equity pool in one way or another. And it's sort of all a big experiment yet to be seen who's going to have the biggest impact and to what populations. And so taking a step back and thinking about it at the highest level, I hope that both of you will indulge me in this one question game that I've created that we can use to wrap up this episode. And I'm calling this game Trend or Traction. Given all that we've talked about today, do you find this focus of health equity to be a trend? And there's a risk that some of the focus might fade away with the next administration or the next sort of policy necessity? Or do you think that this is a focus that has gained real traction over the last few years and is here to stay? Kevin, if you don't mind going first, I would love to hear your perspective.
I think that because health equity is being addressed in so many different ways, I sort of would say that it's both. I think the effort to incorporate either risk adjustment or benchmark adjustment on the basis of historical disparities is definitely going to stay. There's a lot of interest on the part of risk-based providers and value-based payment programs and in health plans themselves to having accurate adjustment for disparities in the sense that that has a big impact on their financial viability of serving these populations. I don't think that's going to go away, even if it's not necessarily called health equity in the future. On the other hand, I think that things like health equity plans, health equity initiatives that are more member communications and just pure care management. I don't necessarily see those things persisting. So that's my perspective on health equity. On social determinants of health, I think that the epidemiological data and the public health data is quite clear on the role of those things. And that's going to continue to be the case no matter what in driving the absolute trend towards more sophisticated population health management and care management and fee-for-service care management initiatives across the entire healthcare system. That's definitely here to stay. What I think is more open is like how far that goes, right? Like social determinants includes everything, including things like housing and employment, income, trauma, experience, many things that are not traditionally insurance benefits. Like there's not going to be a situation where your insurance company is going to be paying your rent, even though your lack of housing is an incredibly powerful social determinant of health. And how far that social determinants of health theory goes from where it's now like pretty much focused on quality improvement efforts and care management, where that goes, I think is really an open question to me. And I think it's a challenge for all of us working in healthcare financing policy to participate in that and make sure that meaningful steps are actually made rather than just window dressing.
Thanks. Very interesting perspective. And Jackie, what about you? Where's your head at? Health equity, social determinants of health, trend, or traction?
I agree with most of everything what Kevin said, especially the social determinants of health. I think it's just a question of where the money comes from, how much money, where it gets allotted. Does it flow through a managed care system? Does it flow through healthcare benefits or something else? Lots to experiment with. But I think overall for health equity at a federal level, it's maybe both. I think the election next year may shift policies, of course, but I also think once things have gained traction, it's hard to go back, like the Affordable Care Act and exchanges. I think despite the political election, certain things, if they're already in place, will be hard to change. They might go under different names, as Kevin said. But at a federal level, it's trend and traction, I believe. At a state level, I think it may change based on state elections. So I think that's traction where it's happening now more than trend. Overall, in general, again, I think the more hard evidence actually we have of improvements in these types of goals and measures, then the more likely they are to stick and have traction. So I think there are so many experiments out there, as Kevin said. The more of them that show hard evidence that they result in improvements, I think the more likely they are to stick around.
Thank you both for taking the time to participate in today's discussion and for all of the discussions that we get to share in the workplace on health equity and where it may be headed. I'm extremely passionate about this topic. I sense that you both are too, and I really enjoy getting to learn from you and discuss with you and work with you on health equity related matters. And thank you to all of our listeners. I am your host, Marjorie Scher. If you like what you've heard today, please don't forget to subscribe. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare and life sciences, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. This podcast is presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of legal services to be performed is greater than the quality of legal services performed by other lawyers.